Stools. Stools should be assessed for type, color, and consistency. By the third or fourth day, stools reflect the type of feeding the infant receives. A water ring should never be present around the solid part of any stool. A water ring is a wet stained area on the diaper where watery stool has been absorbed. There may be an area of more solid stool in addition, or all stool may have soaked into the diaper. A water ring indicates diarrhea and may be caused by formula intolerance or infection. The first stool should be passed within 12 to 48 hours after birth. The nurse should be aware of whether any stools have been passed since birth and, if so, when the infant's last stool occurred. If there is a question about whether the infant has had a stool, the nurse must investigate further. Feeding may cause the infant to pass a stool. Although rectal temperatures are not recommended, the provider may gently insert a thermometer into the rectum to determine patency and stimulate stool passage. Genitourinary system. Kidney palpation. Palpation of the kidneys is not usually performed as part of the routine nursing assessment. The healthcare provider palpates the kidneys just above the level of the umbilicus on each side of the abdomen during the first hours after birth. Abdominal masses may indicate enlargement or tumors of the kidneys. Kidney anomalies may accompany other defects because a problem early in fetal development may affect several organs vulnerable at that time. For example, infants with only one umbilical artery or defects involving the ears may have renal anomalies. The nurse should observe carefully for urinary output in these infants to determine whether the kidneys are functioning adequately. Urine. Most newborns void within 12 to 24 hours of birth, and a few within 48 hours of birth. Because absence of urine output during this time may indicate anomalies, the first void should be carefully noted on the chart. Newborn's bladder empties as little as once or twice during the first 2 days, although more frequent voiding is common. Because of the small amount, the first void may be missed. Sometimes it occurs at birth, but goes unnoticed because attention is focused on the infant's overall condition. If there is a concern about whether the newborn has urinated, the delivery notes should be carefully read to see if the infant voided at birth. The nurse should ask the mother if she has changed a wet diaper. Increasing the infant's fluid intake often can initiate urination. If no void occurs in the expected time, the infant's fluid intake should be increased and the physician or nurse practitioner alerted. By the fourth day of life, at least 6 wet diapers can be expected daily. Each void is recorded in the infant's chart, including the number of diapers changed by the mother. The total number is correlated with that appropriate for the age of the infant. Mothers should be taught that at least 6 wet diapers by the 4th day indicates the infant is taking adequate fluid. If an infant is having feeding difficulties, noting the number of wet diapers is especially important. Disposable diapers are very absorbent, and the pale color of the newborn's urine may cause very little color change on the diaper. Wet diapers generally feel heavier than dry ones. If necessary, the nurse can put on gloves and take the diaper apart to examine it. The absorbent inner lining is damp if urine is present. Cotton balls or tissue placed in the diaper also may be used to increase visibility of small amounts of urine. The newborn's urine may contain uric acid crystals that cause a reddish or pink stain on the diaper. This is known as brick dust staining and may be frightening to parents, who may think the infant is bleeding. It does not continue beyond the first few days as the kidneys mature. Genitalia. The nurse examines the newborn's genitalia for size, maturation, and presence of any abnormalities. Female. In the full-term infant female, the labia majora should be large and completely cover the clitoris and labia minora. The labia may be darker than the surrounding skin, a normal response to exposure to the mother's hormones before birth. Edema of the labia and white mucous vaginal discharge are normal. A small amount of vaginal bleeding, known as pseudomenstruation, may occur from the sudden withdrawal of the mother's hormones at birth. Hymenal vaginal tags are small pieces of tissue at the vaginal orifice. These are normal and disappear in a few weeks. The urinary meatus and vagina should be present. Male. The scrotum should be pendulous at term and may be dark brown from maternal hormones. Pressure during a breech delivery may cause it to be edematous. Rugae, creases in the scrotum, are deep and cover the entire scrotum in the full-term infant. Enlargement of one or both sides of the scrotum may result from a hydrocele. This collection of fluid around the testes may make palpating the testes difficult. Placing a flashlight against the sac may outline the testes. Parents should be told that hydroceles are not painful and often reabsorb within 1 year. Some require later surgery. Palpation of the scrotum determines whether the testes have descended. Testes feel like small, round, movable objects that slip between the fingers. If the testes are not present in the scrotal sac, they may be felt in the inguinal canal. An empty scrotal sac appears smaller than one with testes. Undescended testes, cryptochidism, occurs on one or both sides. Approximately 50 to 70% of undescended testes in full-term infants will descend within 3 months. If the testes do not descend within 12 months, surgery is performed to preserve fertility. The meatus should be at the tip of the glans penis. It may be abnormally located on the underside of the penis, hypospadias, on the upper side, epispadias, or on the perineum. The prepuce or foreskin of the penis covers the glans and is adherent to it. Attempts to retract it in the newborn are unnecessary and can cause injury. Abnormal placement of the meatus may not be visible because it is covered by the prepuce, but often the prepuce in these infants is incompletely formed. Hypospadias may be accompanied by chordee, a condition in which fibrotic tissues causes the penis to curve downward. These conditions are later corrected by surgery. Parents are very concerned about any abnormalities of the genitalia. If the meatus is abnormally positioned, they need an explanation of the condition and why the infant should not be circumcised. The foreskin may be needed for later plastic surgery to repair the defect. Integumentary system. Skin. The newborn skin is fragile and shows marks easily, especially in infants with fair coloring. Because the skin is so sensitive, reddened areas and rashes may develop during the early days of life. The nurse should examine every inch of skin surface carefully during the initial assessment and at the beginning of each shift. Marks should be documented and explained to parents, who may be worried and need emotional support. Color. The skin color should be pink or tan. Red, thin skin occurs in preterm infants. Redness, ruddy color, or plethora in the full-term infant may indicate polycythemia. Acrocyanosis is common during the first day as a result of poor peripheral circulation. The infant's mouth and central body areas should not be cyanotic at any time. Blanching the skin over the nose or chest shows the presence of jaundice. Jaundice is abnormal during the first day of life, but common during the first week. A greenish-brown discoloration of the skin, nails, and cord results if meconium was passed in utero. The discoloration may indicate that the infant was compromised at some time before birth, and it is more common in the post-term infant. These infants must be watched for other complications, such as respiratory difficulty. Harlequin color change. Harlequin coloration is a clear color division over the body with one side deep pink or red and the other half pale or of normal color. The cause is vasomotor instability and is usually transient and benign. Mottling. Cutis marmorata. Mottling is a lacy red or blue pattern from dilated blood vessels under the skin. It is usually normal from vasomotor instability, occurring when the infant is exposed to cold, stressed, or overstimulated. If persistent, it may indicate a chromosomal abnormality. Vernix caseosa. Vernix caseosa, a thick white substance that resembles cream cheese, provides a protective covering for the fetal skin in utero. The full-term infant has little vernix left on the body, except small amounts in the creases. A thick covering of vernix may indicate a preterm infant, and a post-term infant may have none at all. Yellow-tinged vernix may result from elevated bilirubin in utero, and green-tinged vernix is caused by meconium staining. Lanugo. Lanugo is fine soft hair that covers the fetus during intrauterine life. As the fetus nears term, the lanugo becomes thinner. The term infant may have a small amount of lanugo on the shoulders, forehead, sides of the face, and upper back. Dark-skinned infants often have more lanugo than infants with lighter coloring, and their darker hair is more visible. Lanugo is assessed as part of the gestational age assessment. Milia. Milia are white cysts, 1 to 2 millimeters in size, that disappear without treatment. They occur on the face, over the forehead, nose, cheeks, and chin. Erythema toxicum. The nurse notes the presence of erythema toxicum, red, blotchy areas with white or yellow papules or vesicles in the center. It is commonly called flea bite rash or newborn rash and resembles small bites or acne. The rash occurs in as many as 70% of newborns. It appears during the first 24 to 48 hours after birth and can continue for several days to several months. It is most common over the face, back, shoulders, and chest. The condition does not result from infection, but should be differentiated from a pustular rash caused by staphylococcal infection or vesicles from herpes simplex. Birthmarks. The nurse inspects all areas of the skin for birthmarks or other changes. The size, color, location, elevation, and texture of all birthmarks should be carefully documented. All marks should be explained as follows to parents who are often concerned. Mongolian spots are bluish-gray marks that resemble bruises on the sacrum, buttocks, arms, shoulders, and other areas. Mongolian spots occur frequently in newborns with dark skin. They are seen in 96% of African Americans, 85% of Asians, and 46% of Hispanics. Although they usually disappear after the first few years of life, some continue into adulthood. A nevus simplex is also called salmon patch, stork bite, or telangiectatic nevus. It is a flat pink discoloration from dilated capillaries that occurs on the eyelids, just above the bridge of the nose, or at the nape of the neck. The color blanches when the area is pressed and is more prominent during crying. The lesions disappear by 2 years of age, although those at the nape of the neck may persist. Nevus flammeus, port wine stain, is a permanent flat pink to dark reddish purple mark that varies in size and location and does not blanch with pressure. The lesion may darken and may become nodular as the child gets older. If it is large and in a visible area, it can be lightened by laser surgery, which is often begun in infancy. Lesions located over the forehead and upper eyelid may be associated with Sturge-Weber syndrome, a serious neurologic condition. Nevus vasculosus, strawberry hemangioma, consists of enlarged capillaries in the outer layers of skin. It is dark red and raised with a rough surface, giving a strawberry-like appearance. The hemangioma usually is located on the head. It may be present at birth or develop by 6 months of age. After growing larger for 6 months, the hemangioma regresses over several years and disappears. No treatment is necessary unless it becomes infected or ulcerated. Café au lait spots are permanent, light brown areas that may occur anywhere on the body. Although they are harmless, the number and size are important. 6 or more spots, or spots larger than 0.5 centimeters, are associated with neurofibromatosis, a genetic condition of neural tissue. Marks from delivery. The nurse inspects the infant for marks as follows that may have occurred from injury or pressure during labor or birth. Bruises may appear on any part of the body where pressure occurred during birth. Bruising or petechiae of the face may be present if the cord was wrapped tightly around the neck during birth, knuckle cord. Bruising on the head may result from use of a vacuum extractor. Petechiae, pinpoint bruises that resemble a rash, may appear on the back, face, and groin. They result from increased intravascular pressure during the birth process. Widespread or continued formation of petechiae may indicate infection or a low platelet count. A small puncture mark is present on the newborn's head if a fetal monitor scalp electrode was attached. The area should scab and heal normally, but is observed for signs of infection. Forceps marks occur over the cheeks and ears where the instruments were applied. Their size, color, and location are carefully documented. Asymmetry or lack of movement of the face may indicate injury of the facial nerve. Other skin assessments. The nurse records other aspects of the skin that may indicate abnormalities. Localized edema may be caused by trauma from birth. Generalized edema shows a more serious condition such as heart failure. Peeling of the skin is normal in full-term newborns. Excessive amounts of peeling may indicate a post-term infant. Documentation. All marks, bruises, rashes, and other abnormalities of the skin must be recorded in the nurse's notes. The location, size, color, elevation, and texture of each mark are described. Subsequent changes in appearance from previous descriptions are also noted on the chart. The nurse may not always know the proper name for each type of mark on the infant's skin. Most agencies have books with pictures of the common skin variations. When in doubt about the name of a mark, a description is sufficient. For example, a nevus simplex stork bite might be described as a flat pink area 1 by 2 centimeters in size over nape of the neck that blanches with pressure. Breasts. The nurse notes the placement of the nipples and looks for extra, supernumerary nipples, which may appear on the chest or in the axilla. Occasionally, the breasts become engorged and secrete a small amount of white fluid, sometimes called witch's milk, a few days later. This condition is caused by maternal hormones and resolves within a few weeks without treatment. The breasts should not be expressed or manipulated because this could cause infection. Hair and nails. The hair on the full-term infant should be silky and soft, whereas hair on the preterm infant is woolly or fuzzy. The nails come to the end of the fingers or beyond. Very long nails may indicate a post-term infant. A green-brown staining of the nails may occur if the infant passed meconium before birth. It is a sign of possible fetal distress. Assessment of gestational age. The gestational age assessment is an examination of the newborn's physical and neurologic characteristics to determine the number of weeks from conception to birth. It is important because neonates born before or after term and those whose size is not appropriate for gestational age are at increased risk for complications. Although the gestational age may be calculated from the mother's last menstrual period and by ultrasonography during the pregnancy, the date of the last menstrual period is not always accurate, and ultrasonography is not always performed. Because the times of development for various fetal characteristics are known, The presence or absence of these characteristics can help estimate gestational age. The estimated age then can be compared with the newborn's weight, length, and head circumference to determine whether the neonate is large, appropriate, average, or small in size for gestational age. Assessment tools. The new Ballard score is often used to assess gestational age based on neuromuscular and physical characteristics. It is designed to assess gestational age from 20 to 44 weeks and provide accurate information within 2 weeks. It is most accurate when performed within 12 hours of birth. A score is given to each assessment, and the total score is used to determine the gestational age of the infant. The new Ballard score is described in the following section. Neuromuscular characteristics. Posture. The posture and degree of flexion of the extremities are scored before disturbing the quiet infant. Preterm neonates have immature flexor muscles and little energy or muscle tone. Therefore, they have extended, limp arms and legs that offer little resistance to movement by the examiner. Flexor tone improves as the gestational age increases, and it moves in a cephalocaudal manner down the infant's body. Full-term infants hold their arms close to the body with the elbows sharply flexed. The legs should be flexed at the hips, knees, and ankles. Posture is scored from 0 for a limp, flaccid posture to 4 if the newborn demonstrates good flexion of all extremities. The legs of infants who are in a frank breech position may be extended more than flexed even when they are full term. Square window. The square window sign is elicited by flexing the hand at the wrist until the palm is as flat against the forearm as possible, with gentle pressure. The angle between the palm and forearm is measured. If the palm bends only 90 degrees, which is the extent of flexion in the adult wrist, and looks like a square window, the score is 0. The gestational age of the infant is probably 32 weeks or less. The more mature the neonate, the smaller the angle until the palm folds flat against the forearm at term, the result of maternal hormones at the end of pregnancy. Arm recoil. Full-term infants resist extension of the arms. In testing for arm recoil, the nurse holds the neonate's arms fully flexed at the elbows for 5 seconds, then pulls the hands straight down to the sides. The hands are quickly released, and the degree of flexion is measured as the arms return to their normally flexed position. Preterm infants may move the arms slowly or not at all and receive a score of 0. Somewhat older infants have a sluggish recoil with only partial return to flexion. If the arms move briskly to an angle of less than 90 degrees at the elbows, the score is 4. Popliteal angle. To measure the popliteal angle, the newborn's lower leg is folded against the thigh, with the thigh on the abdomen. With the thigh still flexed on the abdomen, the lower leg is straightened just until resistance is met. Continued pressure causes the infant to further extend the leg and results in an inaccurate score. The angle at the popliteal space, when resistance is first felt, is scored on a scale of 0 if the leg can be fully extended, to 5 if the angle at the popliteal space is less than 90 degrees. The preterm infant extends the leg farther than the full-term infant. The leg may extend with little resistance if the infant was in a frank breech position at birth. Scarf sign. From the scarf sign, the nurse grasps the infant's hand and brings the arm across the body to the opposite side, keeping the shoulder flat on the bed and the head in the middle of the body. The position of the elbow in relation to the midline of the infant's body is noted. The infant receives a score of 0 if muscle tone is so poor that the arm wraps across the body like a scarf, with the elbow beyond the edge of the body. A top score, 4, shows that the elbow fails to reach the midline. Heel to ear. The heel-to-ear assessment is similar to the measurement of the popliteal angle. However, in this case, the nurse grasps the infant's foot and pulls it straight up alongside the body towards the ears, while the hips remain flat on the surface of the bed. When resistance is felt, the position of the foot in relation to the head and the amount of flexion of the leg are compared with the diagrams. Increasing maturity is identified by the level of resistance and flexion. Record the position when resistance is first felt, because the neonate may relax the leg if pressure continues. This assessment also may be inaccurate in infants who were in a breech position at birth. Physical characteristics. Skin. The skin is assessed for color, visibility of veins, peeling, and cracking. The very preterm infant skin is translucent because it is thin and has little subcutaneous fat beneath the surface. The skin is red, sticky, and fragile, with easily visible veins. In the mature newborn, the skin is thicker and the color is paler. Few veins are visible, usually over the chest and abdomen. At term, vernix is present only in the creases. The full-term infant exhibits some peeling and cracking of the skin, especially around areas with creases, such as the ankles and feet. The post-mature infant has deeply cracked skin that appears as dry and thick as leather. Peeling becomes even more apparent during the hours after birth as the skin loses moisture. Lanugo. Lanugo appears at 20 weeks of gestation and increases in amount until 28 weeks, when it begins to disappear. Most is shed by 32 to 36 weeks. A small amount may remain over the upper back and shoulders, on the ears, or on the sides of the forehead. The infant receives a score based on the amount of lanugo present on the back. Plantar surface. Plantar creases begin to appear at 28 to 32 weeks of gestation and cover the entire foot by term. Although the creases are only red lines near the toes at first, they gradually spread down towards the heel and become deeper. The plantar creases must be assessed during the early hours after birth because creases appear more prominent as the infant's skin begins to dry. For the very preterm infant, the length of the foot is measured to help determine gestational age. Breasts. The nipples, areolae, and size of the breast buds are assessed and scored. In very preterm infants, the structures are not visible. Gradually, they grow larger, and the areolae become raised above the chest wall. The breast buds enlarge until they are approximately 1 centimeter at term. To determine their size, the nurse places a finger on each side and measures the diameter. Use of the thumb and forefinger may cause excess tissue to be drawn together, resulting in an inaccurate score. Eyes and ears. The eyelids are fused until 26 to 28 weeks of gestation. When the ear is assessed, the incurving and thickness of each pinna are rated. At about 34 weeks of gestation, the upper pinnae, which have been flat, begin to curve over. The incurving continues around the ear until it reaches the earlobe at 40 weeks of gestation. The amount of cartilage present in the ears is a more accurate guide to gestational age than the incurving of the pinnae because of the individual differences in ear shape. As cartilage is deposited in the pinnae, the ears become stiff and stand away from the head. The ear is folded longitudinally and horizontally to assess the resistance and speed with which the ear returns to its original state. In newborns less than 34 weeks of gestation, the ear has little cartilage to keep it stiff. When folded, it remains folded over or returns slowly. In the term neonate, the ear springs back to its original position immediately. Genitals. In the female infant, the relationship in size of the clitoris, labia minora, and labia majora is noted. In the preterm infant, the labia majora are small and separated, and the clitoris and labia minora are large by comparison. As the infant nears term, The labia majora enlarge until the clitoris and labia minora are completely covered. Because the size of the labia majora is affected by the amount of fat deposited, the infant who is malnourished in utero may have genitalia with an immature appearance. In the male infant, the location of the testes and the rugae on the scrotum are assessed. The testes originate in the abdominal cavity and begin to descend at 28 weeks of gestation. By 37 weeks of gestation, they are located high in the scrotal sac, and they are generally completely descended by term. Rugae cover the surface of the scrotum by 40 weeks of gestation. Once the testes are completely down in the scrotum appears large and pendulous. Scoring. As each part of the gestational age assessment is performed, the infant's response is matched with the diagrams and descriptions on the assessment tool. The score is compared with the corresponding gestational age. It is important to understand that one or two characteristics alone are not enough to assign a gestational age. It is the total score of all assessed characteristics that determines the gestational age. A difference of 2.5 points is necessary to change the gestational age by 1 week. Therefore, slight differences in the scores of different examiners are not likely to cause significant differences in the outcome of the examination. Gestational age and infant size. The appropriateness of the neonate's size for gestational age is determined by plotting the weight, length, head circumference, and gestational age on a graph of intrauterine development. This score determines how well the infant has grown for the amount of time spent in the uterus. The infant may be small, large, or of appropriate size for gestational age. The infant whose size is appropriate for gestational age falls between the 10th and 90th percentiles on the graph. The large for gestational age LGA infant is above the 90th percentile, and the small for gestational age SGA infant is below the 10th percentile. Further assessments. When an infant's gestational age or measurements fall outside the expected range, the nurse monitors for complications. Specific complications are common to preterm, postterm, SGA, and LGA infants. For example, pregnancy complications may cause a poorly functioning placenta and an SGA infant. LGA infants are also prone to complications. Assessment of behavior. Assessment of the infant's behavior helps determine intactness of the CNS and provides information about the ability to respond to caretaking activities. Because behavior differs at various times after birth, the nurse should be aware of the periods of reactivity and the 6 different states of behavior so that nursing care can be adapted appropriately. Periods of reactivity. During the first and second periods of reactivity, newborns may have elevated pulse and respiratory rates, low temperatures, and excessive respiratory secretions. Careful observation is important at this time, but usually can be done unobtrusively so that parents can continue to enjoy the newborn. During the time between the first and second periods of reactivity, newborns cannot be awakened easily and are not interested in feeding. Behavioral changes. Nurses assess the infant's behavior and alert the physician to abnormalities. Assessment includes the 6 different behavioral states: quiet sleep, active sleep, drowsy, quiet alert, active alert, and crying. Movement between states should be smooth and not abrupt. The Brazelton Neonatal Behavioral Assessment Scale is often used when detailed knowledge about the infant is needed. In addition to assessing behavioral states, the scale analyzes other aspects of the newborn's behavior, such as orientation, habituation, self-consoling behaviors, social behaviors, and the appropriateness of the amount of time in each of these activities. Orientation. The nurse notes the infant's orientation, ability to pay attention, to interesting visual or auditory stimuli. It is most prominent during the quiet alert state. Infants focus their eyes and turn their heads towards a stimulus in an attempt to prolong contact with it. Preterm and ill neonates have less ability to orient to stimuli. Habituation. The infant's response to a visual, auditory, or tactile stimulus is an important assessment. Generally, the first response of a healthy newborn to an interesting stimulus, such as a brightly colored object or bell, is a period of alertness. If the stimulus is disturbing, such as a bright light flash in the eyes, the infant startles and attempts to escape by averting the eyes. Infants gradually stop responding to continued unpleasant stimuli. This gradual habituation allows them to ignore the stimuli and save energy for physiologic needs. Newborns may display a dull, drowsy state or fall into a deep sleep. Those who seem unresponsive in a bright, noisy environment may be in a state of habituation. The preterm infant, or one with damage to the CNS, may not be able to habituate. Self-consoling activities. Normal newborns are able to console themselves for short periods. Self-consoling activities include bringing their hands to their mouth, sucking on their fists, listening to voices, and watching objects in the environment. Infants who are ill, preterm, or exposed to drugs prenatally have less ability to console themselves. Parents' response. The parent's growing ability to respond to the infant's behavioral cues should be noted. The nurse can point out the infant's behavioral changes to facilitate attachment and help the parents learn to interpret the infant's cues. The methods the parents use to meet the infant's needs during different behavioral states are also noted.